Okay. Assalamualaikum warahmatullahi wabarakatuh. You can hear me, right? Okay.
Yes.
I'll proceed. Okay. My name is Kamila binti Maklumahatin and I will present about bipolar disorder. The bipolar disorder is a chronic and complex mood disorder characterized by combination of manic, hypomanic, and depressive episodes. The periods of mania are known to be the highs, while periods of depression are the lows. However, bipolar bipolar disorder does not only affect the mood, but also the individual's thought and behavior that affect that affect one's ability to function. Okay, these are the subtypes of bipolar and related disorder as listed in the DSM-5. They are bipolar 1, bipolar 2, cyclothymic disorder, substance-induced bipolar and related disorder, bipolar and related disorder due to another medical condition, other specified and unspecified bipolar and related disorder. And I will talk about bipolar 1 and bipolar 2 while the rest will be presented by Brother Izzuddin. So epidemiologically, survey done on 11 countries noted that the prevalence of bipolar 1 disorder is 0.6%, while for bipolar 2 disorder is 0.4%. And the mean age of onset is in the early 20s, and women are slightly more affected, whereby when women are slightly more affected. However, many episode and bipolar 1 disorder is more common in male, while bipolar 2 disorder is more common in female. So the etiology of bipolar disorder can be caused by a variety of factors, which can be categorized into biological, genetic, and psychosocial. So for biological factors, it is known that there is brain chemical imbalance, whereby the neurotransmitter or chemical imbalance in the brain. This is because the neurotransmitter or chemical in the brain appear to play a role in many mood disorder. For example, the dopamine is noted to be increased in mania, while it is noted to be decreased in depression. Other than that, the hormonal imbalance may also trigger because hormones greatly influence our feelings. So for the genetic factors, studies have shown that bipolar disorder is more likely to emerge in a person whose family member is affected with the condition, whereby risk of bipolar disorder is 10 to 25% when one parent has mood disorder, double the risk if both parents have mood disorder. For the environment, for the psychosocial factors, for environmental factors, there are any stressful or traumatic events such as abuse or significant loss can lead to the emergence of this disorder. Okay, for the two types that I will talk about is the bipolar 1 and bipolar 2 disorder, whereby in bipolar 1, the individual must meet the criteria of many episodes which may have been preceded or followed by hypomanic or mood major depressive episode. While for bipolar 2 disorder, the patient must meet criteria of hypomania plus major depressive episode. So, okay, for mania and hypomania, it's generally viewed as happy and euphoric states. However, certain individuals may have irritable or dysphoric highs, whereby the individual will feel easily annoyed and easily provoked to anger. Okay. So this graph show the oscillations between mania and depression. it shows the differences between bipolar 1 and bipolar 2, whereby in the graph here, for the bipolar 2, it does not reach to the mania level. Okay. To diagnose an individual with mania or hypomania, they must fulfill the criteria.
So for bipolar 1 disorder, so how many percent of those with bipolar 1 disorder initially presented with depressive episode?
For bipolar 1, I'm not sure about the percentage.
Okay, normally they present more with manic presentation or depressed presentation?
More with manic, while for bipolar 2, it's more commonly with depression.
No, I mean I'm talking about initial presentation. So initial presentation of bipolar 1, depression or manic. Can somebody with bipolar 1 initially presented with depressive symptom?
Can.
Huh?
Sorry, doctor.
Boleh ke tak boleh?
Boleh?
Can somebody with bipolar 1 initially presented with depressive episode?
Yes, they can present with depressive episode first.
Boleh je. It doesn't matter what. It doesn't matter how you presented earlier, but once you had many episodes and you become bipolar 1 disorder. So it is very possible that somebody with bipolar 1 did not get diagnosed to be bipolar 1 initially. So they may be diagnosed as either bipolar 2 or bipolar or unipolar depression. So my question was, how many percentage of those with bipolar 1 presented first as depression?
Sorry, doctor, I don't know about the percentage.
So majority ke minority? Yes, sir.
I think it's minority.
Sebenarnya majority.
Sorry.
Okay. So around 60% of those with bipolar 1 will initially started off with depressive symptoms. Okay, so my next question is, so that means whoever presented with unipolar depression, one of your differential must be bipolar disorder. And cumanya, in which situation or what are the characteristics of those with unipolar depression yang menyebabkan kita suspicious of bipolar 1 disorder? Faham tak salah saya? Do you get my questions or not?
Boleh doktor repeat balik?
Okay, now, let's say you have one patient.
Okay.
This patient presented with unipolar depression. Okay, so what are the characteristics of this patient that will make you think that maybe this is actually a bipolar 1 disorder yang has not yet had dia punya first manic symptoms. So apa features yang kita kena be careful or be cautious? Faham ke tak faham?
Faham.
Oh, okay. So, or anybody else? Any answer? Ada anybody want to guess? Okay, let's go satu-satu. I just want you, even you haven't read about it, you should be able to think about it just yet. So, kalau kita tengok with the onset, okay. So, what kind of onset yang make you think pasal bipolar?
What kind of onset? Mania onset? Is it?
Unipolar depression tu, onset dia yang macam mana yang akan menyebabkan you rasa macam, onset dia ni macam pelik sikit lah. Nampak macam bipolar je.
I'm not sure, doctor.
Early onset ke, late onset ke? What is the onset? What is the onset of depression?
The onset.
What is the natural onset of depression? Siapa yang present depression early on? Apa onset? Tadi you mention pasal onset of bipolar kan?
Yeah.
So you know bipolar presented 18, 20s. Depression pula present bila?
Depression.
Depression kan? Faham tak maksud onset ni?
Oh, faham.
Maksudnya bila patients normally akan dapat
All the onset?
you all represent the depression kan? You should have some idea pasal onset masa cerita pasal epidemiology of depression kan?
Yes, yes. Um,
Okay lah. Onset of bipolar dengan depression yang mana dulu?
Bipolar dulu, depression lagi
Bipolar
lagi.
is much earlier. Sebab apa? Sebab apa agak-agak?
mungkin it's sebab dia more related to family punya biological factors.
Okay, true. So majority of depression sebenarnya related dengan life stressors. Okay. So therefore bila orang start ada life stressors, life problems, bila?
Bila dah start dah besar.
In adulthood. So that's why, because if you look at depression, among common risk factor dia relationship problem, domestic violence, financial stressors, interpersonal conflicts. So therefore, onset of depression generally is a bit later, 30, 40s baru you see depression. Tapi kalau you see somebody who is depressed at the age of 16 for example, 16 dapat depression, yang suicidal, yang psychomotor retardation. So you need to think pasal possibility of this is actually a bipolar disorder yang first presented as unipolar depression. Itu maksud saya. Maksudnya when you look at unipolar depression tu, you had some ideas pasal apa yang menyebabkan you nak letak bipolar as your differential. What is your justification untuk you think about possibility of bipolar disorder as differential diagnosis? Okay, so that is onset. Ataupun the other extreme is a very late onset of unipolar depression. So pun again something yang you nak consider. So maksudnya depression that occur in the abnormal ataupun out of normal typical age onset. Lagi apa lagi? Kalau if we talk about specifier, okay, which specifier of depression yang akan menyebabkan you rasa this is potentially can become a bipolar?
Mixed features.
Okay, so bipolar with mixed features. So macam mana, how do you differentiate bipolar with mixed features and bipolar 2 disorder? How do you differentiate depression with mixed features dengan bipolar 2 disorder?
For depression with mixed features, the features of mania or hypomania is not full criteria. Dia tak meet all the full criteria.
Okay, so maksudnya dia almost macam manic or hypomanic yang tak fully form, faham tak? Maksudnya dia macam bau nak jadi. Dia macam ada bunga-bunga ke arah manic or hypomanic. And so we call it mixed features. And for the sake of we know we are treating depression. However, given the mixed features of it, we need to be careful tentang possibility of this is actually a bipolar depression. Kenapa kita nak base? Why is it matter untuk differentiate whether it's unipolar depression or bipolar depression other than diagnostic point of view?
It's for the management because
Okay, so management, because of the management. What would happen kalau kita treat patient with unipolar depression with patient with bipolar depression with antidepressant?
dia akan either change to mania punya episode.
Okay, so dia akan switch to manic episode. Okay, so kalau patient with unipolar, we weren't so worried because that is what they need. They need antidepressant. Okay, alright. Lagi? Ada anything else? How about the features of the depression tu? Selain specifier, ada any specific symptoms yang kita akan buat kita fikir yang it could be actually a bipolar depression? A bipolar presentation.
Hmm. Hmm.
Any idea?
I'm not sure, doctor.
So of all the symptoms of depression, yang mana yang kita need to be careful, yang it could be actually a sign of bipolarity, suicidality, okay? Patient with unipolar depression presented first episode dengan suicidality, you need to be careful tentang depression. In terms of treatment, macam mana from the treatment of unipolar depression will give you some idea that it can potentially be a bipolar disorder.
When we give the antidepressant, the patient's mood switch to the manic episode, manic
Okay, so
symptom.
that is obvious lah. Tapi other than that,
Other than that, I'm not sure about the other reason.
orang lain, term of treatment. What about it? When you look at the treatment, make you think macam, ni macam bipolar ni. Anybody else? Ni semua soalan-soalan kita tanya long case. Common clinical questions. Kalau you bagi patient saya depression dengan antidepressant, apa you punya likely outcome?
Patient antidepressant, wait. Sorry doktor, kalau kita bagi patient depression,
You bagi antidepressant. Apa you punya likely outcome?
like the outcome,
Apa? Saya lah kereta bising. Apa?
the patient will not be depressed.
Patient improve lah. Kan? You bagi treatment
patient
yang
improve.
intended to treat the depression, patient will improve. Therefore, jawapan dia apa? Saya bagi hint tadi.
Not improve.
So failure to respond to multiple treatment of antidepressant. Maknanya you tukar antidepressant tak sihat juga. You tukar antidepressant tak sihat juga. You naik dose pun tak sihat juga. Tak okay juga. Still suicidal, still ada psychomotor retardation, still ada insomnia. So you need to be thinking pasal possibility of this is actually not unipolar depression that we're dealing with. It's actually a bipolar depression. Okay? So all of these are things that you need to know bila kita deal with depression, and in order untuk kita decide on kita punya diagnosis and differential diagnosis. Okay, carry on. The SM5 ni tak payah explain lah, baca sendiri je.
Okay. Just M5. So dia punya symptom pun tak payah explain ke doktor?
No need to explain. Any problem dengan symptom? Anything that is not clear?
Anyone? If not, I will proceed.
Okay, carry on.
So for the diagnostic, to diagnose bipolar 1 disorder, just like what I've said before. So this table show the differences between bipolar 1 and bipolar 2, whereby in bipolar 1, there is presence of manic symptoms, while in bipolar 2, there is hypomanic with no manic symptoms. While for the severity, bipolar 1 is more severe compared to bipolar 2. And
Yang ni ambil daripada mana?
Ambil daripada, saya tengok sini punya slide.
Macam mana?
Slide sini.
Okay, so this is incorrect. So just disregard this. Okay? Kenapa saya kata it's incorrect? Let's say you have bipolar 2 disorder with depression and suicidal. Severe ke tak severe?
Severe.
Okay, so kenapa you kata bipolar type 2 is less severe? So it's incorrect. You cannot just, sebab dia ada bipolar 2, dia tak adalah teruk sangat. Bipolar 1, teruknya dia ni. So it's incorrect. Incorrect way of differentiating. The only valid or the only correct differentiation is yang atas tu je. Manic hypomanic symptoms tu saja. Alright, yang lain tu semua tak accurate in differentiating between bipolar 1 and bipolar 2 disorder.
For the
Alright,
functioning,
apa juga? Kenapa you kata bipolar type 2 functioning not impaired? Sedangkan in order for you to diagnose any depressive or hypomanic episode, one of the punya kriteria dia mesti disturb in functioning kan?
disturb in functioning, tapi doktor kalau macam ikut kriteria number E tu, the episode is not severe enough to cause marked impairment.
But that is for hypomanic punya presentation. And tapi in depressive episode, patient akan ada severe function.
Oh. Okay.
Okay?
Okay.
Okay. So tak payah ingat comparison tu, we won't be asking you this kind of comparison. So beza dia cuma kena ingat tu je. Bipolar tu tak ada manic. Tu je beza dia.
Okay. Okay, so after diagnosing bipolar disorder, we must specify the bipolar disorder, whether it's with rapid cycling, with psychotic features, with mixed features, with atypical features, anxious distress, peripartum onset, or seasonal pattern. So I just want to talk about the rapid cycling, whereby rapid cycling is defined as at least 4 episodes of mood disorder within the same 12-month period dengan syarat the patient has partial or full remission at least 2 months or there is switch to opposite polarity. Boleh faham tak?
Faham tak?
Kalau tengok the graph here, so this patient has ada 5 episodes of mood disturbance, tapi but there is no remission or partial remission for at least 2 months, so the patient still can be considered as rapid cycling. Faham tak? Okay, proceed. So differential diagnosis depends on whether if the patient presented with depressive episode or manic or hypomanic phase. This has been listed by our CPG. For the comorbidities, bipolar disorder is commonly associated with anxiety disorder first, and then followed by substance misuse, and then the rest like PTSD and OCD. For mental state examination, it is as stated here. Maybe you can read it later, or if you have any question, you can ask. So this the diagram that I found on the internet. For this screening, these are the screening tools available, which is usually used in primary care. So for the management, the aim is to ensure patient safety and nearby people safety as well, and also to achieve clinical and functional stabilization with least possible side effects and prevent relapse. Management of bipolar disorder can be divided into acute and long-term. So the first management task is to confirm the diagnosis of mania or hypomania and clarify the current mood of the patient. So because the treatment approach may differ. Then we must assess the severity by using the Young Mania Rating Scale. If the patient have a young mania rating scale to assess the severity, whether it's mild, moderate, or severe, and then decide whether the patient require hospitalization or not. And then for the treatment, it's, as I said before, it's divided into acute and long-term management, or also known as maintenance. For patient that requires inpatient management, the criteria is listed in our CPG is the patient has risk of harm to self or the people surrounding them, and the treatment is not suitable to be started as outpatient. Okay, for the investigation, we can divide it into three: biological, psychological, and social or spiritual. So the biological, we must know whether we want to do a diagnostic or baseline investigation. I think it's just about the same, just like what the depression presentation before. And then, okay, it's just about the same. Just for to assess the severity of mania by Young Mania Rating Scale. This is the Young Mania Rating Scale. The total score ranges from 0 to 60, and the scoring here, if the patient scored between 13 to 19, the patient had minimal symptoms 20 to 25, the patient has mild mania 26 to 37, moderate mania 38 to 60, severe mania. So there are 11 items that should be evaluated using this Young Mania Rating Scale. So for the treatment, I also divide it into pharmacological and non-pharmacological. By pharmacological, there are two. To start, whether it's monotherapy or combination therapy. Combination therapy, usually we use mood stabilizer and antipsychotic because it shows greater response than treatment with monotherapy. Then for non-pharmacological, we have electroconvulsive therapy and the other psychosocial intervention. And the management also can be divided into biological, psychological, social, and spiritual. For biological, in pharmacological, the treatment varies between the acute phase and maintenance phase. For the pharmacological, the types of drugs that are commonly used in bipolar disorder are the mood stabilizer consisting of lithium and anticonvulsants, and then there is antipsychotics and antidepressant. For lithium, lithium is considered as gold standard before. However, it has narrow therapeutic index. Narrow therapeutic index. However, the current
what do you mean by narrow therapeutic index?
The narrow therapeutic index.
Apa? Hello?
Ya doktor.
Apa?
Dia punya
Apa maksud narrow therapeutic index?
To reach the therapeutic punya level, the risk for toxicity increase.
Not quite. So narrow therapeutic index ni maksudnya dose or level between therapeutic and toxic very close. Faham tak?
Okay.
So maksudnya macam mana, how do we decide therapeutic index ni? How do you decide how to use lithium? Based on
the serum lithium in the patients.
Okay, so based on level. So apa dia punya therapeutic level?
Therapeutic level 0.6 to 0.8.
Okay, so apa dia punya toxic level?
Toxic level more than 1.5.
Okay, so maknanya from 1200 mg per day for example, dengan toxic maybe beza dia 600 mg je. Just another one additional tablet akan switch patient from improve to intoxicated, ataupun maksudnya dapat dangerous side effects from the medication. Itu maksud dia. So maksudnya it's very good. Okay, it's not that we we disregard lithium as one of the option. Cumanya bila kita guna, we need to be extremely cautious because one day patient will be very well, the next day patient terlebih satu tablet aja, patient become toxic, masuk ICU bagai. So that's basically what it means lah.
Okay.
Okay, carry on.
Okay, for anticonvulsant, we have carbamazepine, valproic acid, and lamotrigine. These anticonvulsant have mood stabilizing effect.
Carry on.
Okay, and then antipsychotics, there are two types, whether typical and atypical. The second generation or atypical antipsychotic. Sorry. Okay. So the typical antipsychotics, the example is haloperidol, while the atypical antipsychotics example is risperidone, olanzapine, aripiprazole, and many more. And also used antidepressant. However, antidepressant should not be used as a monotherapy because just like what Dr. have said before, because it can just like what Dr. has said before lah. So these are the common side effects for the commonly used medications for lithium. The common side effects are polyuria, polydipsia, weight problem, hypothyroidism. So we need to monitor the patient thyroid function during follow-up. And then for sodium valproate, or known as epilene, the most common side effects are sedation and weight gain. So better to tell patient to take the medication during bedtime because it can because of its sedative effect. And then lamotrigine, Lamictal or Lamitor, or we have to know the side effect is notable side effect is rashes, because these rashes have risk for severe skin reaction such as the Stevens-Johnson syndrome or toxic epidermal necrolysis. I don't remember the end. Then the next one is carbamazepine or Tegretol. The common side effects are fatigue, nausea, neurological symptoms. Okay. So the algorithm for treatment of acute mania is to decide whether to use monotherapy or combination therapy. Okay, I'm not sure if there is any difference between bipolar 1 and bipolar 2 preference, but okay. This the pharmacological treatment for maintenance risk in bipolar disorder. You can read this later. For the risperidone long-acting injection, it is considered if the prophylaxis against recurrence of mania is required and adherence to oral medication is erratic or injection is preferred for the patient. And then for the challenges in treating the patient is for the rapid cyclists and the mixed features, because rapid cyclists is associated with difficulty to treatment. So the treatment stated here is what I read from the CPG. For non-pharmacological, we have electroconvulsive therapy, which can be considered in patients with severe symptoms of mania, high suicidal risk, catatonia, intolerance, or no response to medication. So the psychosocial intervention, there are 5, which are CBT, interpersonal and social rhythm therapy, group psychoeducation, family-oriented intervention, and early warning signal. So the differences between these I have divided in the table. The aim for CBT is to identify to identify, challenge, and replace unhelpful thoughts, the patient, to a more helpful ones. While for IPSRTs, to regulate sleep-wake patterns, the patient, sleep-wake patterns, work, exercise, meal times, and other daily routines. Okay, maybe you can read this later on. For the prognosis for bipolar 1 disorder, for good prognosis, the patient must have good insight and no suicidal thoughts. While for poor prognosis, usually associated with male patient, early age of onset, presence of psychotic features, coexisting medical comorbidities, and poor family support. That's all.
Boleh dengar tak?
Boleh doktor. Cuma bergema sikit.
Ada one more topic kan?
Ada bergema.
Ada one more topic ke?
Yes, one more topic.
Carry on.
Okay.
Assalamualaikum Doktor. Can I ask one question?
Okay, the last page ni ada forms of mood disorder ni, you just go through quickly je because it is actually not really so common disorder, but you need to know for untuk understand other possible differential diagnosis whenever patient presented with mood disorder. Okay.
Okay. Sorry Kamil, boleh tutup slide tu tak? Buka slide.
Boleh dengar saya?
Boleh tak?
Hello?
No.
Assalamualaikum Doktor. Before we proceed, can I ask one question? Kamil dia tak apa.
Tanyalah Umairah.
Okay. Actually I want to ask, sorry if I misunderstand from the presentation just now.
Okay.
The acute manic and acute depression, in terms of the treatment, is it those two are choices? For example, that the presentation, the patient is more on depression, so we choose the algorithm from the acute depression. Does it mean like that?
From my understanding, yes, it's like that.
Ya. Saya tak dengar. Azudin dah start present ke belum?
Belum Doktor.
Okay, thank you Kamilia.
Tak apa, you start present dulu. Saya pergi cari replacement earphone.
Okay. Bismillahirrahmanirrahim. So I will proceed with the next topic, which is the last one, entitled Other Forms of Mood Disorder. So it can be divided into two. Either it falls under depressive disorder or bipolar and related disorder. So we will go one by one very quickly. So the first one, persistent depressive disorder, or also known as dysthymia, it is actually a milder form of depressive disorder with longer duration and less severe symptoms. So the core concept of it, it refers to three features. The first one, it is low grade of depressive symptoms, and in terms of chronicity, which is it may last for at least 2 years. And about the onset, it is insidious or gradual, and usually it starts during childhood or adolescence, as compared to MDD, which is during adulthood. And the third one, it must be persistent or intermittent, and it is not sufficiently severe to fit the diagnosis of MDD. So epidemiologically, it is common among the general population with the prevalence about 5 to 6%, and it is more common in the women less than 64 years old as compared to the men of any age, and also common in unmarried and young person, and in those with low incomes, and also in those with first degree relatives with dysthymia or MDD, and also usually coexist with other psychiatric illness such as MDD itself, anxiety, substance abuse, and borderline personality disorder. Okay, this is the diagnostic criteria. I think you can read it by yourself.
So apa beza diagnostic criteria PDD and MDD? What makes it different?
Okay, the main difference is the in terms of the time frame, in which in dysthymia, we need for adult at least it persists more than 2 years, and for children and adolescents at least 1 year. And then in terms of the symptoms, in dysthymia we only need 2 out of 6 symptoms to fulfill the criteria, but in MDD we need at least 5 of the symptoms of the depressive symptoms.
So, so number one is duration, number two is symptoms count. Okay, but how would you differentiate somebody yang ada chronic, persistent, recurrent MDD dengan PDD? How else would you differentiate it?
Doctor, sorry, your voice is not clear lah.
Dengar tak? Hello, dengar tak?
Dengar tu tapi slow sikit.
Slow, okay. Macam mana, how do we differentiate PDD from somebody yang ada recurrent relapses of MDD? Because they can also have symptoms for years.
Okay. If you want to diagnose it as PDD, there must be no symptoms free for more than 2 months. So if it is, let's say, if it is recurrent of MDD, maybe there should be symptoms free when it achieves remission more than 2 months.
So somebody yang kita nak diagnose recurrent should have already achieved some level of remission for at least 2 months period. Macam, so how do we know patients in remission? Itu saya dah ajar. How do you define remission?
The patient gets into normal function back, and
Lagi?
also in terms of the symptoms, it does not fill the criteria.
So when patients no longer fulfill the required minimum required criteria to diagnose dia punya original disorder. So let's say somebody who's depressed, so dia ada residual poor concentration, lethargic, tapi that's the only symptoms yang dia ada. And so it persists more than 2 months within that, with that remaining symptoms, and boleh functioning, then kita dah consider dia in remission. Okay, alright, carry on.
Okay, so disable, it shows about the differences of PDD and also MDD. The gist of it, basically PDD is milder than MDD lah. Okay, in terms of the treatment or management, there are pharmacotherapy and also non-pharmacotherapy. For non-pharmacotherapy, there are a lot of psychosocial therapy that can be used to the patient, but the most common one or the treatment of choice is insight-oriented or psychoanalytic therapy. The aim of it is to increase patients' insight about the emotional issues and conflicts that underlies their presenting difficulties. And the others you can read lah. And then for the pharmacotherapy, usually we use SSRI and also monoamine oxidase inhibitors.
So generally the psychological therapy for PDD, MDD is pretty much the same. And apa role of antidepressant in PDD?
Role of antidepressant.
We use antidepressant to treat PDD?
Based on the book that I read, usually we more focus on the psychotherapy.
Okay, so it's not first line treatment, and normally we don't give it in isolation. So maksudnya you should not treat somebody with PDD with antidepressant alone. They will less likely to improve. So normally they need some form of ongoing psychological therapy. What do we call kalau patients ada both PDD and MDD?
Double depression.
Double depression. Okay, so bila patient ada double depression, then we treat it as MDD. Okay, so maksudnya whatever treatment modalities yang kita offer in MDD, even though patient ni ada underlying PDD, kita treat it as MDD. But once they improve from the MDD, normally this kind of patient will not return 100% to the baseline, sebab dia punya baseline tu dah memang ada depressive features to start with. Okay, carry on.
Okay.
Cepat, kita nak ada discussion.
Okay, the next one is premenstrual dysphoric disorder. By the name itself, it is a depression related to the menstrual cycle, which usually occur a week prior to the menstruation and will disappear after that. And can be quite severe and impair patient's social, academic, and work functions. So, and then in this type of disorder, there are also presence of somatic symptoms such as breast tenderness, abdominal bloating, headache, and swelling of extremities. So it's quite easy to differentiate with other kind of this depressive disorder because of the somatic symptoms and also related to the menstrual cycle.
So somatic symptom tu tak really helpful in differentiating because patient with depression can also have somatic symptom. Sebenarnya the only differentiating feature tu sebenarnya adalah dia punya temporal relationship dengan menstrual cycle.
Oh, okay. Okay, so should I go with diagnostic criteria?
Tahu ya?
So yeah. Okay, in terms of treatment, for biological therapy, usually we use antidepressant, SSRI for it, and biological antidepressant and also hormonal therapy. So no psychosocial therapy.
Carry on.
Alright. The next one is disruptive mood dysregulation disorder. Okay, this one, it is diagnosed for those in between 6 to 18 years old of age who presented with severe and frequent temper outbursts, with chronic severe irritability, sad or anger, which interfere with the function at home, school, or relationship, in which the symptoms is inappropriate with the child's developmental age, and it must occur at least 3 times per week for at least 1 year. And there are common comorbidities with it, such as ADHD, anxiety disorder, MDD, autism spectrum disorder, self-harm, and also suicidal behaviors. And the children with this kind of disorder later will usually develop depression and anxiety.
Right. So normally we see disruptive mood dysregulation disorder ni dengan somebody yang to begin with dah ada already issues. So psychosocial issues. Contohnya somebody yang ada underlying ADHD, lepas tu ada poor attachment, ada abuse. So sometimes we get one of the punya presentation tu is mood, and because ADHD cannot explain the mood, and therefore suddenly kita use another diagnosis to explain it, which is disruptive mood dysregulation disorder. And cumanya disruptive mood dysregulation disorder ni is diagnosis yang baru-baru ni je come up. It's basically sebenarnya a lot of it tu sebenarnya adalah underlying psychosocial issues yang resulting in mood problem.
Okay. Shall I go with this doctor?
Carry on.
Okay, in terms of treatment, just like doctor said, it is like a new diagnosis. So the pathophysiology is not really known, but there are some drugs that are shown to be response towards it, such as antidepressant, stimulant, and also atypical antipsychotics. But we can also give psychosocial therapy such as CBT. Okay, the next one is cyclothymic disorder. Okay, if dysthymia is a milder form of depressive disorder, this one, cyclothymic disorder, is a milder form of bipolar disorder characterized by episodes of hypomania and also mild depression. It affects about 1% of general population. Female is more common, and most of the patients have onset between 15 to 25 years old, and the risk factor is having a first degree relative with bipolar 1, and usually it coexists with borderline personality disorder. So this is the diagnostic criteria. Okay, in terms of the treatment for biological therapy, the first line is mood stabilizer and also anti-manic drug, since it likes bipolar disorder, and the dosage is about the same with the bipolar 1. And just like the doctor mentioned before, if you are about to give antidepressant to the patient, we have to do it with caution, because it may induce antidepressant-induced hypomanic or manic episodes. And we can also give psychosocial therapy to the patient. Okay, the next one is substance or medication-induced mood disorder. So by the name itself, it is a mood disturbances due to direct physiological effect of substance or medication. which develop soon after exposure, intoxication, or withdrawal, and the substance or medication must be capable of producing the symptoms. And the diagnostic features are essentially as the same with bipolar and depression. And the symptoms must not precede or follow after cessation of the intake of medication or substance. And it must be supported by clinical history, physical examination, or laboratory findings
Apa
of
common
usage.
substance that can give rise to depressive symptoms?
Sorry, Doctor?
Apa example of substance that can cause depressive-like symptoms?
This is the example of the substance.
Okay. Macam mana amphetamine cause depression? Amphetamine kan stimulan.
Um,
Apa what would happen if somebody takes stimulant, orang ambil ais, shabu, kuda, jadi apa? Tak pernah jumpa orang ambil ais.
Schizo.
Schizo? No.
Manic je.
Manic, euphoric.
Stimulant very rarely cause psychotic symptom. Kenapa orang ambil ais, ambil shabu? Kenapa? What is the most common reason why people bagi tahu dia ambil ais dan shabu?
Euphoric.
You pernah jumpa patient ambil ais shabu ke tak? In your life before? Or no anybody?
Tak pernah.
Lagi.
Okay. Kenapa orang ambil ganja?
Really stress.
Jadi
Sebab nak high.
Kenapa dengan ambil ganja
Dia happy.
because basically you high. Okay, so bila you high, you forget about your problem lah. Okay, so normally we commonly see orang yang ambil cannabis related substance ni orang yang ada stress related. Orang yang stress biasanya dia tak ambil stimulant. Okay, kenapa? What will happen if you take stimulant? Nama tu pun you boleh agak dah stimulant. So dia apa? Kenapa dia dipanggil stimulan? Kenapa? Taklah. Kenapa dia dipanggil stimulan?
It stimulates the mood.
Because it's stimulating. Okay. So bila stimulating the mood ke whatever, dia akan jadi apa? Dia akan jadi macam apa? Presentation dia macam apa?
Dia akan jadi happy.
Presentation dia macam manic.
Okay.
Alright. So macam mana stimulan cause depression? Kalau stimulan sebenarnya essentially stimulating medication. Masa dia stimulan cause depression? During which period?
Saya rasa bila effect of stimulant tu dah habis dah.
Okay, so what do you call that?
Withdrawal effect.
Withdrawal.
Okay, itu je saya nak dengar. Okay, so basically effect of the substance can occur sama ada during intoxication or during withdrawal. So kalau dia berlaku during withdrawal pun kita panggil dia substance induced. Okay, so maksudnya kalau dia ambil stimulan dia jadi manic, so kita panggil dia substance induced bipolar related disorder. Tapi kalau dia ambil substance, lepas substance tu tak ada, dia jadi depressed, dia fulfill depressive punya features tu, persistent, what not, dan kita panggil dia depressive disorder due to stimulant withdrawal. Due to substance use, basically stimulant withdrawal. Okay. Alright, so continue.
Okay, this is the diagnostic criteria. You can read after this. So for bipolar disorder. In terms of the treatment, first we need to identify the involved substances and stop the intake of it. If the symptom persists, then we need to give antidepressant or anti-manic drugs. The last one is mood disorder due to medical condition. So by the name itself, it is a mood disturbances due to the medical condition. So we need to establish whether the mood disorder is related to the medical condition and no other mental disorder. So these are the examples of the medical condition that can cause
Okay, so
like
kalau you ada elderly patient, dia apa namanya, dia jatuh bila air, dia ada fracture of femur, and because of that dia tak dapat pergi masjid, dia tak dapat keluar, dia terperuk dekat bilik, dia bedbound, and then eventually dia depressed. So can you call that depressive disorder due to medical condition?
I think no, doctor.
Kenapa tak boleh?
It's more like because of the stressor, not to the.
Kenapa tak boleh? Tak boleh. Why cannot we consider the medical condition to as the cause of dia punya depression? Sebab kalau
Because
dia tak ada fracture of femur, dia tak ada depression.
Because the medical disorder of the patient, medical condition of the patient is not the primary cause of the depression.
Primary cause dia ni lah, fracture of femur lah. Tak ada fracture of femur, tak ada lah depression. Right? Dia terbentang di depan mata you tu jawapan dia.
I think yes. It
Yes.
can be. It can be because like after, if the medical condition is treated already, so the depression will be gone.
Okay. Not quite. Sebenarnya the answer is you cannot say in that condition it is mood disorder due to medical condition, but the answer is there. I want to hear it because you've already highlighted it. Tapi bila you highlight pun you don't know what you've highlighted. Baca balik your first sentence tu.
Mood disturbances due to direct physiological consequences of the neuromedical condition.
Okay. So if the medical condition is fracture of femur, so can femur of fracture explain physiologically depression?
Oh, tak boleh.
Cannot lah. Okay, if you look at examples of medical condition yang on your right side tu, every single diagnosis tu physiologically can explain mood disorder. For example, hypothyroidism. So hypothyroidism ni akan leads to symptoms of lethargy, psychomotor retardation because of reduce in metabolism. Multiple sclerosis, so it affects brain, and one of the areas in the brain that affected is limbic lobe, which is responsible for your mood. So therefore, it can physiologically explain the mood symptoms. So if you take femur fracture for example, macam mana how do you relate you punya femur fracture tu dengan depressive symptoms physiologically? You cannot kan? It may be directed psychologically and socially, but not biologically. Okay, so psychologically maybe you say because of femur fracture, reduce in function, dia rasa hopeless, correct? So therefore you call it what? You call it depression. You don't call it depression due to medical condition. So you only reserve this diagnosis in the diagnosis where the diagnosis itself can present with depression or mood symptom as one of dia punya physiological changes, that pathophysiological changes that happen. So you have to understand dia punya. So same goes to substance. So even though there is a substance related mood disorder, but in order for you to say that the substance is related, one of the punya fundamental requirement adalah the substance itself must be physiologically able to produce such symptom. Okay, so therefore, let's say you have one substance yang orang abuse, petrol for example, and then bila patients sniff petrol, patient develop psychosis. However, physiologically, petrol cannot produce psychotic related symptoms. Therefore, petrol tu should not be the cause of the psychosis. You have to think about other causes. Maybe dia ni memang already ada underlying schizophrenia. So sebab tu this diagnosis is separated from the actual diagnosis in case the cause tu bukan primary. Because if you look back at MDD, one of their punya diagnostic criteria adalah it must not be explained by sama ada other psychiatric disorder, medical or substance. Okay. Alright. Sikit Sekejap ada referral. Carry on.
So this is the diagnostic criteria of it. Basically, it's just about the same with the substance induced. So the difference is caused by either medical condition or substance use. So the treatment, we need to treat the underlying causes. So that's all for me. This is my references.
Okay, sekejap saya ada consultation kejap. Kita break 5 minit sekejap. Okay, carry on Asya.
Okay, patient ni ialah 40 years old. Kami dah di 20 of admission. Dia
Siapa?
Dia 40 years old Malayman.
Siapa?
Dan nama dia
Mazuki. Okay. Mazuki yang substance kan?
Dia substance.
Okay. Apa isu dia?
Dia tanya plan nak discharge. Dia pun kakak dia call tadi. Kakak dia plan nak hantar di IC. Penuh ACT pun terima sebab tak discharge COVID. Lepas tu nak hantar kat Satya tak terima sebab dia macam tak boleh masuk India dengan ada rate. So kakak dia call. Ini tahu kata sebab hari tu dia ada buang barang-barang maju. Dia punya barang dadah sebagainya. So nak bagi balik hari ni tak ada tempat placement, tak ada takut Mazuki sampai buang mengamuk.
Okay. Tapi kita tak bolehlah simpan dia. Kita tak bolehlah simpan dia sampai dia jumpa tempat nak discharge. Apa plan dia? Dia kalau dia ada definitive plan tak apa. Kalau dia tak ada plan then cannot.
Dia tak ada definitive plan sekarang.
So
dia cuma plan dia ialah kalau buat hal lagi dia akan bawa lokat chat. Dan tahu kita lah.
Boleh, tak ada masalah. Mazuki sendiri macam mana sekarang?
Mazuki sendiri juga ada. Cuma kita masih pun substance.
Tapi dia psikotik ke tak?
Tak psikotik, dia memang well for discharge.
Okay, kalau in term of judgement tu, you tengok dia macam ada ni apa judgement ke, still marah kat kakak ke, still ni ke?
Tak, dia dah macam nak lupakan dah. Dia dah tak apa? Dia dah tak ada dendam kakak dia sebagainya. Dia okey kakak dia.
Dia ada tempat lain nak duduk ke tak?
Dia duduk kakak dia duduk dengan mak dengan ayah dia. Ayah dengan abang.
Okey, dah tu kenapa kakak dia yang
hari-hari pergi masak untuk ayah dia. Ayah tak sihat. And then kakak dia polis nasihat kakak dia tu buang semua-semua tu.
Okay.
Kakak dia buang lah.
So I think macam ni, you explain to Mazuki, this is what happened. Maksudnya when you come back, maybe because of what happened, semua barang-barang you apa semua tu dah tak ada. What do you think? Maknanya awak tanya dia, adakah you akan marah ke, adakah you akan upset ke apa. So kalau dia kata tak apalah, saya tahulah nak buat macam mana, dah buang macam tu, then you just explain that, okay, if that's the case, kalau you balik, you still mengamuk ke apa ke, you will be, family akan bawa you pergi ke polis lah, because it's not because of mental illness. Maknanya kita just explain what will happen, and then dengan family pun sama. Kita kena explain dekat family yang okay, we already explain to Mazuki yang barang-barang dia tak ada semua tu, and then dia pun okay ke tak okay whatever, and then maknanya macam agreement, basically an agreement lah bersama, because what will make it different minggu depan, minggu lagi satu, so sama je. Maknanya kalau kita keep dia minggu depan pun tak ada juga tempat nak discharge, dia akan possibly balik ke family juga. So so cakap kat kakak, we cannot keep him indefinitive sampai COVID settle ke, sampai ada tempat nak ambil dia ke, because here dia dah well, tak ada psychotic symptom, it's all related to substance, and dia ada insight. If it happen again, then dia kena take the consequences lah. Just explain macam tu je lah. Okay. Ke you rasa ada option lain? Kalau kita keep discharge minggu depan, sama je, isu dia akan sama. Akak dia akan cakap benda sama juga. Alamak, saya dah buang barang dia, sama juga. Memang anyhow dia akan face the consequences, and family have to face the consequences jugalah. Cumanya kita dokumen properly lah. Maknanya kalau malam ni dia datang balik kata Mazuki psikotik semua tu, it cannot be true lah. Maknanya just baru discharge, tak ada apa-apa, you cannot use that reason lah. Just charge je lah. bawa ke polis je lah. Oh, you all dengar? Tak apa, tak apa. Tak, ni student saya cuit dengar. Okay lah. Alright. Sure, thank you. Assalamualaikum. Dah habis juga. Alright. Dah ada dah semua? Okay, we carry on. Alright, so we will continue dengan discussion. So hopefully with the discussion ni, if there's any other questions related to mood disorder crops up, then we can discuss it according to the case that I shared with you lah. So have you all completed the questions or not?
Yes.
Okay, alright. Just saya nak tunjuk slide sekejap. Setup slideshow. Okay, alright. So get ready with your answer. Saya tunjukkan ni. Boleh nampak saya punya ni? Boleh nampak saya punya ni kan? Saya punya slide kan? Boleh tak? Nampak. Okay, alright. So let's start. So first case, 61 years old Malay man, retired prison officer with underlying hypertension, obesity, hyperlipidemia, presented with clinic with chief complaint of change of behavior for the last 6 months. Okay. So change of behavior ni is very non-specific. So maybe kata dia jadi pelik, dia jadi lain, dia jadi macam tak sihat, dia jadi macam tak betul. Whatever terms that patient use, as I highlighted, they presented with the experience. Kita yang kena see it through sama ada it's psychotic, mood, anxiety, whatnot. Okay. But the duration that was highlighted was 6 months. Okay, so his wife reported that he has been ignoring his self-care and refusing to do his daily routine, such as going to mosque or meeting his old friends like he used to do. He's been spending time on his own in his room and ruminating about his past sin. Ruminating ni apa? Ruminating ni apa?
Think deeply.
Macam asyik bercakap, reiterating.
Okay. So ruminating ni, you all dulu belajar dekat sekolah haiwan ruminasi tak?
Lembu.
Apa contoh ruminating animal?
The bovine species.
Lembu.
Sebab apa lembu haiwan ruminasi?
Because they have 4 compartment of rumination GI.
Rumination tu apa? What they do when they ruminate?
They recycle.
Basically dia makan, lepas tu dia keluar balik, dia makan semula. So that is rumination. So kalau rumination thoughts apa? Maksudnya you keep on coming to that thoughts again and again. And contohnya you make mistake in the morning, in the afternoon you think about it again, and then at night you think again, you think about it, why did I do that, why did I do that, why didn't I do that, why didn't I do that. So that kind of behavior tu kita panggil ruminating. So in his case, he was ruminating about his past sins. Okay, so he keep on expressing to his wife that it was sinful and was and no longer able to pray. He was no longer able to pray, and this may be due to his past sins. So this is what he believes. All right. Okay. So first question is, what are the three initial differential diagnosis and why do you think so? So this is something that you will get in PMP, but basically, even though it is PMP oriented the way I ask the questions, tapi sebenarnya what I want try to highlight adalah whenever you encounter patients during interview, even in real life to life, day to day punya encounter, or in clinics or in exam, you kena berfikir seperti PMP. Maksudnya you have to have questions in your mind in order for you to know what do I want to know next? What do I want to know next? What is my direction of the interview? If you don't have any of this in your mind, basically dia akan jadi macam berbual-bual je lah. Okay, and that's not the case. Because sometimes psychiatric patient ni memang seronok berbual. And in later, if you come in the ward patient and manic, you can talk with them for hours. But that's not the idea or the intention of speaking to patients with psychiatry. The idea is so that we'll be able untuk diagnose and manage. Okay, so in order to come up with the diagnosis, you have to have some sort of thinking process in mind. Okay, so one of the things that we need to do to start with adalah start with initial differential diagnosis, which basically kita nak decide direction of kita punya next questions. Okay, so siapa nak start dulu bagi jawapan? So group 1, give one differential diagnosis and reason.
The first one would be major depression disorder with psychotic features due to the patient have depressive.
Major depression disorder, major depressive disorder. Okay, so number 1 is major depression. Why do you think it's major depression? Reason?
Because the patient seems to have depressive symptoms and the duration is more than 2 weeks. And
which depressive symptom?
Which depressive symptoms? He has impaired social functioning.
Okay, so impaired social functioning exclusively for depression sahaja?
No.
Okay, so every single diagnosis under DSM mostly ada depression and function. So therefore you cannot use this depression and function as your first defense to say that this is depression. Okay, do you know what I'm trying to get to you adalah macam mana you nak answer PMP yang ada markah. Okay, because sometimes what happen in PMP, you guys write a lot of things, but we cannot score you because you haven't specifically mentioned the keywords that we're looking for. So if you look at these questions, dia nak differential diagnosis with reasons. So bila trigger 1, basically reason dia can only come from whatever in the trigger. So bila kita kata reasons, which basically means what's in the trigger yang support your idea or your premise or your suggestion that it is depression. Itu je soalan tu want to know. So you have to be specific with your answer in order for you to get marks. Right, so come back to my questions. What in the story yang make you think that this is depression?
The patient has anhedonia because he refused to do his daily routine like he used to do.
So good. So one possible reason is the symptoms of refuse to go out may represent loss of interest. Lagi? Another one?
The other one is excessive feel of guilt.
Okay. So another one is guilt. Okay, so patients ada guilt. Alright, so remember, whenever we ask you why do you think patient has this diagnosis, you punya jawapan mesti dua sahaja. Satu, depend on symptom. Kedua, depends on supported by whatever features yang patient ada. Okay, so maknanya bila tanya soalan, kenapa why do you think this patient is schizophrenia? You kena think about apa diagnosis criteria yang dia fulfill atau dia ada. So jangan jawab, or sebab dia 61 years old, or sebab dia man, sebab dia retired prison officer. None of that is supportive of depression. Okay, so always think dalam that framework whenever we ask that question. Okay, good. Can you answer? Oh, dia ada problem for the last 6 months. Can you notion that patient has depression? Can or not? Hello?
Oh, tak boleh sebab kat sini kita tak tahu lagi.
Dah, dia tulis kat sini tu 6 months.
Oh.
Maksudnya, kalau you answer, I think one of my differential diagnosis is depression. Reason is because patient has been unwell for 2 months. For 6 months. Boleh ke tak boleh?
Saya rasa boleh betul.
Boleh.
Tak boleh sebab dia tak spesifik.
Because being unwell for 6 months, ni cancer pun boleh unwell for 6 months. Saya patah kaki pun boleh unwell for 6 months. It is not exclusive for depression. It is not something yang bila dia ada 6 months je, you just think, mesti depression. No. Okay, so you have to give answer yang justifiable with the diagnosis. Okay, good. So that's first one. We're thinking pasal depression. So maybe because this is mood disorder punya case, so you thinking pasal depression. Second, group 2.
I would like to put bipolar disorder.
Bipolar disorder. Full? Manic ke?
Because it fulfill one of the criteria in hypomanic.
Hypomanic. So tak, maksud saya bila tak diagnosis, you kena letak diagnosis full. Bipolar disorder tu bukan full diagnosis. So bipolar disorder currently in hypomanic, you think?
Yes.
Okay, why?
Because the mood change is observed by other people.
Mood is observed by other people.
The disturbance in the mood and the change in function are observable by others. One of the criteria of hypomanic.
Hypomanic je ke yang ada diagnosis tu?
No.
Depression, cyclothymia, disruptive mood disorder, semua tu tak boleh be observed by others ke?
Ada juga.
So boleh ke guna alasan tu?
Tak.
So no, cannot get, you won't get marks for such. Bipolar disorder can be one of the things that you can consider, tapi you need to come up with other justification. Ada anybody want to help? Ada anybody else? Any other group yang ada bipolar related punya diagnosis? Apa betul guru? You all dengar suara saya clear
Clear, doktor.
Okay, alright. Ada tak any other group yang think along the line of bipolar?
Yes.
Ya, ada.
So what's your diagnosis?
From group 7. Bipolar disorder currently in depressive.
So you think it's bipolar disorder currently in depressive. Why?
Because the patient actually have a depressive symptom. However, the patient have depressive symptoms such as he has ignoring his self-care and refusing to do an social impairment. However, we need to inquire more if there is any hypomanic or manic symptom.
Alright, so at this stage, you nak kata dia unipolar depression, you nak kata dia bipolar depression, dua-dua boleh. Because we haven't got enough information untuk distinguish between those two. Tapi you need something to support yang it's bipolar depression. So okay lah. So bila you ada features to support depression, then okay. Tapi kalau you nak kata this is bipolar currently and hypomanic, do you have anything to support your hypomania ke tak?
I don't think so, doktor.
So tadi siapa tadi?
Saya doktor.
Farid. Farid, ada any other hypomanic features yang you boleh nampak daripada situ?
Macam tak ada.
Tak ada kan? So hypomanic apa? Basically sama je dengan manic symptoms kan? So elevated mood, irritability, increased agitation, spending spree, poor sleep. So none of that uh, uh, none of that nampak lagi at this stage. So you cannot offer that diagnosis. Alright. Second. Quick, second. Third. So second one tadi bipolar depression. Third, group 3.
For group 3, Doctor, we put late onset schizophrenia in prodromal stage.
Okay, so you are thinking tentang schizophrenia related. Okay, so your reason, your supporting features.
Because the patient's he's an elderly male, change in behavior and ignoring self-care for 6 months.
Elderly male tu takkan dapat markah. Sebab dia diagnosis ni, you nak support schizophrenia tu. Late onset Alzheimer's is just supporting features je. So
Right.
apa yang support schizophrenia in this case?
The change in behavior.
Okay, what change in behavior?
Like what the wife reported that he had been ignoring his self-care for this and then refusing to do it.
So that can relate to what diagnosis of schizophrenia?
It's a schizo in prodromal stage.
No, maksud saya, kan saya cakap tadi, bila you nak justify any diagnosis, you kena support dengan number one, symptom, number dua, supporting features. Okay, so symptom apa yang you nak relate dengan schizophrenia? With what you change?
Negative symptom kan.
Symptoms of disorganized behavior.
Okay, so it could be one negative symptom or it could be disorganized behavior. Okay, faham tak sekarang ni apa yang saya nak you all macam mana you all nak berfikir untuk menghadapi soalan? Faham tak?
Faham je, faham.
Okay, so maknanya pertama fikir diagnosis. Kedua fikir reason. Nak cari reason, kena tengok apa yang ada dalam cerita ni, lepas tu relate dengan diagnostic criteria of that diagnosis. Macam contoh tadi, you fikir depression. So, bila depression, you kena ada sama ada depressed mood, loss of interest, guilt, blah 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 semua tu. So, of all these criteria, ada tak yang connected dengan the way dia present? So, dia macam ada rasa bersalah semua tu. So, that is guilt. So, guilt is depression. And so, itu yang kita nak you write. And sebab we want you to tell us you are thinking pasal this. This is actually what you need to do whenever you clerk patient. So bila you clerk patient cakap, saya rasa bersalah lah doktor. So dalam kepala you terus berfikir, guilt, this sounded like guilt. So guilt can be no emotion. Guilt can be a feature of depression. So I want to know more about depressive symptoms, whether they fulfill or not, before I can include or exclude this as one of my depression diagnosis. Faham Alright, so schizophrenia, one is change of behavior. Ada tak anything else yang you nak guna untuk support your schizophrenia punya features?
Doctor, about he said that about his sin, can we say that the patient is having delusion of sin or guilt?
Okay, good. So that is also another way of approaching it. Maksudnya you hypothesize patient's punya presentation tu and relate it to the diagnosis. So patient ada sins. So bila somebody ruminate, bila somebody preoccupied about sins, this can be actually a form of delusion. Tak, dia adalah delusion of guilt. So delusion of guilt ni is a delusion. Delusion ni falls under criteria, diagnostic criteria of schizophrenia. Okay, good. Okay, fourth differential, group 4.
Our differentials are the same as mentioned by group 1, 2 and 3, Doctor.
Okay, yang lain? Ada tak your differential yang tak ada dalam figure?
Doctor, sorry, I'm from group 7. Can it be adjustment disorder with depressive features?
Adjustment disorder, okay. So,
that we still haven't know.
So apa yang macam how do you diagnose adjustment disorder with depressive features?
There will be events that cause change.
Okay, so far dalam ni ada tak anything yang anything yang supports you untuk
Uh,
kata
they, I don't think so.
okay, alright. Now, it still can be one of differential tapi dia punya value dia bawah. So you may not get full marks for that. You may get macam 0.5 marks for that. Sebab dia macam basically macam jauh sangat lah. Faham tak Salma? Dia understand tak jauh sangat? Faham tak Salma?
Yes.
Yeah,
faham doktor.
It's too far. Macam you're just picking it on from air. Alright. Any other differential?
Our group.
Yes.
Schizoaffective disorder.
Okay, why?
Because he has ignoring self-care, loss of interest, and excessive guilt.
Okay.
And he has delusions as well.
Okay, so to justify schizoaffective disorder, you need two cluster of symptoms, which basically one is what? Schizoaffective.
One schizoaffective, so psychotic and mood symptoms.
Good. Okay, so as long as you have symptoms yang falls under psychotic punya criteria, and then at the same time ada symptoms yang falls under mood punya symptom, then schizoaffective can be one of the possible differential diagnosis. Okay, good. Next one.
Doctor, can it be substance-induced depressive disorder?
Okay, so substance-induced at this stage anything can, as long as you can justify. So how would you justify substance-induced?
I can only justify the depressive symptoms,
okay.
Which is patient has anhedonia,
Sama lah,
asociality.
mana depression tu sama macam depression tadi tu. Tapi what makes you think substance?
At this point macam tak ada, doktor.
Okay. So maknanya dia drop down. Maknanya you basically you are justifying it as a depression. You're not justifying it as substance-induced depression. Cumanya if you're thinking pasal substance, you also need to be thinking pasal apa?
Medication.
Okay, now substance may be far-fetched given that this is 61 years old. Why now he wants to take substance? So medication is another possibility. Sebab for 61 years old with underlying medical problem, antara substance dan medication yang mana more likely dia ambil?
Medication
lah kan. Okay, so you just have to think logically. Okay, now the next question is, if you think medication-induced depressive disorder, what medication do you think can cause depression?
Parkinson medication.
Sorry?
Parkinson.
Okay, so Parkinson medication. Lagi?
Can be antihypertension.
Which one?
I'm not sure.
Beta blocker. Think about the medical causes of depression and macam mana dia relate dengan medication. Okay lah, saya bagi hint. Patient ada hyperthyroidism. Macam mana dia boleh dapat depression?
Anti-thyroid medication.
Okay, so we over-treated dia punya hyperthyroidism, menyebabkan dia punya thyroid level reduce. So kita dapat basically a medication-induced depressive disorder. Now, again, this is a potential differential diagnosis, tapi you wouldn't put it in your top 3. Why? Because the amount of information that you have cannot support you. It's just macam maybe dia ambil anti-Parkinson. Kenapa tiba-tiba you think dia ambil anti-Parkinson pula? Ada anything ke yang kat situ support anti-Parkinson punya features? No. And so therefore maksudnya you may think tapi dia macam jauh-jauh sikit lah. Lower down in your options. There are things yang sebenarnya higher up but you haven't thought about it. Yang akan help you to score marks better. Yang lain-lain tadi tu semua 0.5. Apa yang can get you 2 marks?
Can it be generalized anxiety disorder.
Generalized anxiety disorder, good. Okay, why?
First, because the patient refusing to do his trivial daily living activities such as going to mosque and meeting his old friends.
Why does it make generalized anxiety disorder?
Because there is some degree of social impairment in.
So, social impairment ni ada dekat semua diagnosis. It doesn't make it generalized anxiety disorder.
The
Okay,
change of
yang saya sebut banyak kali, pick yang exclusive to that diagnosis.
first change of behavior.
Change of behavior ni semua benda change of behavior, Zairul. Apa yang ada dalam tu yang makes you think pasal possibility of anxiety related disorder? May not be generalized anxiety disorder tapi anxiety related disorder. Apa?
Asociality.
Asociality. Okay. So you thinking pasal apa? Diagnosis apa?
Social anxiety tu.
Okay, so social anxiety disorder. So maknanya adalah substance you nak thinking pasal dia ni macam tak nak keluar rumah ni macam orang yang ada social anxiety. So maybe social anxiety is one of my differential diagnosis. Okay, lagi? Ada anxiety disorder? Ruminating about past sins. What bless you? Ruminating about past sins. What kind of anxiety punya symptoms possible?
Obsession compulsive disorder.
Okay, so it can be an obsession because obsession ni features dia adalah keep on repeating intrusive sampai dia punya mengganggu. Alright, so it can be a form of obsession. Cuma kalau saya letak di bawah-bawah. It's not what I'm thinking. There's something else yang more common. Generalized anxiety disorder. Okay, so generalized anxiety disorder ni dia punya main symptom dia is preoccupation with worries. Okay, so that can be a rumination. Okay, ada lagi diagnosis yang lebih relevan. Ni pun jauh dekat anxiety pun bawah-bawah. Saya bagi satu markah je. Okay, saya bagi hint lah. 61 years old. Underlying medical problem and disturbance in function.
Dementia.
Okay. So, disturbance in function adalah supporting features untuk all mental illness. Cuma the only mental illness yang disturbance in function tu dia punya diagnostic criteria. Main diagnostic criteria. Which is basically dementia. Maknanya dementia ni kalau tak ada disturbance in function tu dia tak ada symptoms. Sebab symptoms dia dua je. Disturbance in memory and second is disturbance in ordinary function, day-to-day function. Okay. So could this be dementia? Why?
Yes, because ruminating, there is idea of ruminating. And
ruminating tu tak makes it dementia. Apa yang makes it dementia?
Underlying medical illness dia ada.
Okay, macam how do you relate to dementia?
Hypertension, obesity and hyperlipidemia may cause vascular dementia.
Good. Okay, so diagnosis ni adalah vascular dementia, major neurocognitive disorder due to cardiovascular problem. So you punya reason adalah patient presented with situation in function. Lepas tu with the background of underlying medical problem yang can contribute to vascular events. So therefore dementia ni is more likely. So if you think about it, antara depressive disorder due to substance dengan dementia, yang mana yang you sepatutnya lebih cenderung? So of course dementia kan. Tapi kenapa dementia sampai hujung dan nak habis pukul 12 ni baru keluar dementia? Because you were not thinking about it. And possibly because this is mood disorder punya seminar. In real life, patient tak datang ikut seminar. Patient tak datang ikut posting. Patient comes with problem. So you need to think in a holistic way. Start berfikir seperti seorang doktor. I I always emphasize that by this time, whenever you approach any situation, any clinical encounter, start berfikir as if you are the only medical officer work in the district hospital with no other support. The only support you have is what you have underneath your skull, provided that there is something underneath there lah. Okay. Okay, carry on. Ada tak anything else? Can it be mood disorder due to medical condition? Boleh ke tak? Boleh ke tak?
Boleh.
Okay, kalau boleh apa which medical condition? Jangan cakap Cushing.
Cardiovascular illness.
Ha?
Obesity, mana dia?
Metabolic syndrome.
You kata obesity boleh buat depression, saya cekik nanti. Sorry, nama?
Metabolic syndrome, because he has like.
So how metabolic syndrome physiologically cause depression? Cannot. Can I said the only way you can use a medical condition to diagnose somebody with mood disorder due to another medical condition if that medical condition physiologically can explain depression. Okay, so what? Apa agak-agak?
Cerebrovascular accident.
Okay. So
causing depression.
Cerebral vascular event causing depression. Can stroke cause depression? Can stroke physiologically explain depression? Why? How?
Yes.
Because it affects the limbic system.
Okay. So kalau stroke dia dekat hospital, you cannot use that as your diagnosis because hospital stroke cannot physiologically explain depression. Betul tak? Because occipital lobe has nothing to do with your mood. Tapi kalau dia ada lacuna infarct in subcortical region, then you can explain it. So therefore, it's a valid diagnosis. Okay, sama juga dengan tumor, for example. If you have tumor at orbital dekat occipital lobe, you cannot get depression because it's not physiologically related. So antara stroke dengan tumor, yang mana yang more likely in this case? Stroke lah. Okay, alright. So of all these diagnoses, now please rearrange according to likelihood. 1, 2, 3. Best top 3. Faris. Number 1?
Number 1, major depressive disorder.
Okay, number 2?
Number 2, dementia.
Number 3?
Medical illness causing depression.
Okay, good. Alright. Now, bila you ada banyak differential diagnosis, how do you decide which one yang you nak letak top 3?
The one that has the most likelihood to be the professional.
Memanglah. Yalah, macam mana how do you decide which one yang has most likelihood of becoming the professional? You kena tengok.
Get points for and points against it.
Macam mana you nak diagnose mental disorder? Saya bagi tahu. 1, 2, 3, 4. 1.
Kena fulfill DSM-5 criteria.
Number 1, symptom. Number 2?
Timeline, time frame, time frame.
Number 3?
Function.
Number 4?
Exclusion.
Okay, so you go by this. Mana yang paling banyak 4 benda ni, that will be your most likely diagnosis. So maksudnya contoh number 1 is criteria. So you have 5 options. The one yang ada 3-4 diagnostic criteria yang fit will go higher. Yang ada 1 sahaja will go lower. Contoh generalized anxiety disorder, ada berapa? Yang supporting generalized anxiety disorder ada 1 je. So you cannot make generalized anxiety disorder on your top list. Okay, faham tak? I want you to be thinking and jangan just listing out of nowhere. And sometimes saya dengar orang akan jawab, saya jumpa kamu kos jawab professional diagnosis schizophrenia. Reason sebab 6 months. You're not thinking. You're just listing. Oh, sebab schizophrenia 6 months. Therefore, I want to put schizophrenia in my. You have to differentiate yourself from somebody yang dah learn about it dengan somebody yang just read about it somewhere. Okay, carry on. Kita ada banyak lagi ni. Good. So 3 important things you want to ask to distinguish your differential diagnosis. Alright. So macam mana nak jawab bila soalan ni tanya macam ni? How would you answer it? Okay, saya bagi contoh Alright. One of your differential diagnosis is tadi adalah major depressive disorder due to another medical condition. Okay, so if that's your differential diagnosis, 3 important things you want to ask to in order to establish that. Apa? So siapa yang jawab stroke tadi tu? Huzai. So apa 3 things yang you want to find out?
I would like to ask regarding the other symptom of the stroke.
Okay. For example,
any extremities weakness.
Okay, good.
Any slurred speech.
Okay, number 2 tu semua you letak 500 symptom stroke pun you akan dapat satu point je. Number 2,
the premorbid, the control of the morbidity such as the hypertension, obesity,
good.
and
I'll give
hyperlipid.
mark for that as well. 3, macam mana you nak bezakan orang yang ada depression due to stroke dengan orang yang ada depression dan stroke? Apa?
The onset. Which one start first?
Okay. Don't you want to know that?
Yeah. I would like to know which.
Because will the answer to that question help you to distinguish the diagnosis?
Yes.
So therefore that's what needs to be included, because the question is 3 important things you want to ask to distinguish your differential diagnosis, which basically means the answer to that question will help me to say whether this is diagnosis ni is likely or not likely. Contohnya kalau you letak dekat situ whether the patient has good family support. That is questions yang important as well, but will that question help you to differentiate your diagnosis or not? No, so you won't get mark to that. Ataupun you nak tanya presence of family history of mental illness. So that's also important question to ask, because that is one of the things yang kita find out from clinical psychiatric laki. Tapi that answer to that question will not help you to distinguish whether it's mood disorder due to medical condition or mood disorder due to or primary mood disorder. Okay, faham Okay, one more. Just nak bagi clear lagi. Tadi okay, Salma you give answer of schizoaffective. So what do you want to know in order for you to decide whether this is likely schizoaffective or not likely schizoaffective? 3, 1.
How do I say this? Also, we can ask about which one comes first as well, the onset.
Okay. So in schizoaffective, which one comes first?
Or schizoaffective. The psychosis. I don't know.
Schizoaffective is schizophrenia with mood symptoms, which basically means you cannot have schizoaffective without schizophrenia. Okay. All right. Next, what else you want to know? I know you haven't had schizoaffective seminar. Ke dah sudah?
We had schizophrenia.
Dah. So you should be able to answer. Anybody else? what else important to know in order to establish whether it's schizoaffective or not?
Can we know that majority of mood symptoms happen during the illness or not?
Okay, so if patient has psychosis, whether mood symptoms be present in duration, okay, good. Because if it's there, then it helps. If it is not there, then schizoaffective become less likely. Alright, lagi? Third, you haven't asked about psychotic symptom, and we haven't established that there is psychotic symptoms. So therefore, ada atau tak ada psychotic symptom tu is important. And so that means you have to include that. Sama ada you nak tahu patient ada hallucination ke, patient ada delusion ke. Okay, so whenever you want to ask this kind of questions, okay, remember what you're looking for adalah what you need to diagnose that diagnosis. So it goes back to principle yang saya ajar. You need symptoms, you need duration, you need function, you need exclusion. Of course, dengan short amount of time, what you can highlight is predominantly is essentially symptoms lah. Okay, some of you bila kita ask this kind of questions, you will answer family history, personal history, past history of trauma, past history of abuse, pre-morbid personality. You can write whatever you can write whatever along this line, but it will not carry marks for you unless that particular thing helps you to differentiate. Now, what diagnosis yang pre-morbid personality tu helps you to differentiate the diagnosis to is likely or not likely?
Schizophrenia.
Kenapa pula?
Contoh macam schizotypal or schizoid is more predisposed to schizophrenia.
But ada schizophrenia, ada schizoid, ada schizotypal, will it rule in or rule out schizophrenia or not?
Sorry, Doctor?
Having schizotypal or schizoid personality, does that rule in or rule out schizophrenia or not?